Dr. Reganyon from Philippine Heart Center. So I am tasked to talk on the procedure that I presume we all know, but I would concentrate on the tips and tricks, the strategies on doing PDA, pre and intra-procedural. So I intentionally closed the figure 8 because I found out that there are so many ways to skin a cath, so many ways to do stenting of the PDA inside the cath lab. I have nothing to disclose. This is our institution, our center. And this is our cath lab, the regular cath lab. We have 4 rooms and 1 biplane room dedicated solely to pediatric interventions, and 1 hybrid operating room equipped with Artery robot arm. So this is our census for the past 20 years. And if you take note, there's a downward trend of diagnostics and a steady uptick of our interventions, especially last year, where we have 426 interventions and 192 diagnostic procedures. So year-on-year basis, this is our total output, almost 4,000, of course 3,000 adult procedures. And last year alone, we have 624 pediatric interventions. And total PDA stenting from 2010 to 2018 is 96. Actually, we started way back 2007 in collaboration with our adult counterparts, but the stenting program for PDA started actually 2010. So this is the distribution of our cases. PDA stenting alone, and sometimes in combination with balloon valvuloplasty and atrial septostomy. So how's to stent the PDA? Of course, you start with puncture and vascular access. You do descending aortogram, then you size the PDA from this angiogram. After that, you deploy the wire. After PDA sizing, positioning, anchoring the wire. Then, of course, inflation, deployment of the stent, then inflation of the balloon, then removal of the wire, and if necessary, but we usually do a post-stenting angiogram after the procedure. So this is the simpler case of PDA, wherein the PDA takeoff is a small angle from the descending aorta. So the first tip is, of course, you start with vascular access. We have institutional protocol of 3 below 3 kilograms. The sheath of 3 for neonates, young infants less than 3 kilograms, and a maximum French 4 for arterial catheterizations and French 6 for the venous side. And of course, this is one of the harder case, the vertical PDA, 3 weeks old, TOF PVA. We're able to access coming from the antegrade approach from the right side of the heart, because this is TOF PVA with dilated aorta overriding, so we can cross through the RVVSD in dilated aorta, and it's very good to access the PDA coming from the antegrade approach. So this is a vertical PDA. In the past, it used to be excluded, but now we are doing a vertical PDA in our center if the anatomy allows us. And of course, we also ask the help of our surgeons. This is a carotid artery access through surgical cut down. We utilize our hybrid room. So this is the sheath. The advantage is the sheath is almost at the mouth of the PDA, and we can manipulate. It's a very safe distance from the mouth of the sheath, and we can dilate the PDA, the balloon and the stent. So 12 days old case of pulmonary valve atresia. This is another difficult case. We have a PDA, good access from the femoral arterial side, but during the procedure and during the angiogram, the saturation went down to as low as 20 to 40. So we prioritize. We do the stent first. Although we know that the RV side has good morphology, tripartite RV with good RV body, inlet and outlet, we prioritize the stenting because the saturation is going down as low as 20s. Then we go to the right side of the heart, and it's almost a pulmonary valve atresia, but we were able to cross the atretic valve. But the problem is during the crossing, one wire the stent cannot pass through the valve. So what we did is another body wire or double wire as a support, but that wire we shoot through the stent and the descending aorta, and we choose which wire is the best anchorage for this type of PDA. We choose to retain that one through the stent and through the descending aorta because that's a good anchorage. A segue to Dr. Choi's lecture before, DTGA IVS. We also had one case, 5 days old of DTGA. Okay. And there's a closed PDA at the time that we sent the patient at the cath lab. So on angiogram, okay, you notice the closed PDA. So we were able to open a bit of the PDA through direct prostaglandin injection, and we were able to wire it, then do the stenting procedure. So this one, we do a telescope stenting of the PDA, overlapping stent over stent. Okay. So if you notice the aortogram, there are two constrictions. So we prioritize the proximal side. We did a stent on the proximal side, and we telescope the distal overlapping stent, almost 1/3 of the distal stent overlapping the proximal stent. Now this one is a closed stent. Right after stenting, there was thrombosis, but we were able to access through the wire. And our mistake here is there's a short. We underestimated the length of the PDA, so we're able to rewire the stent and then double the length. Of course, we measure the length, the allowance from the ampulla up to the pulmonary artery, so we were able to do a restenting the stent procedure in this patient. So here's the overlapping stent, and we maximize the pressure up to 4.2, so there's a good apposition of the two stents and minimize the risk of embolization and migration of this patient. Now, this is a staged ductal stenting. We have a constriction right after the ampulla, but the ampulla is quite large, 5. So what we did, we prioritize the distal constriction, not the ampulla side of constriction. Then we have an induced restenosis of the ampulla. 24 hours after, off prostaglandin, the saturation went down, so we went back to the cath lab and restent the proximal side where the ampulla constriction happens. Okay, so this is a staged ductal stenting, but you should be careful because you are inducing a restenosis of the PDA. You take up the prostaglandin, you should monitor the patient. Once the saturation is going down, then that's the time to go back to the cath lab and restent or overlap or telescope the two stents. Okay, of course, with the knowledge where the constriction of the ampulla PDA. Now, this is an antegrade PDA stenting, this critical PS, and we were able to shoot the wire through that critically closed valve. Then we prioritize the PDA through the antegrade approach. We stent the PDA, then we don't remove the wire. We did not remove the wire, then do a percutaneous pulmonary balloon valvuloplasty on the antegrade. But it is quite tricky because if you notice, the marker and the tip of the balloon is almost opposing or touching the stent. So there's a risk that you might embolize the stent. So the markers of the stent is a good landmark where your limit is. Of course, you have to size the balloon and the stent so you have a good result with this kind of patient. Critical PS, small PDA, 1 month old, antegrade PDA stenting, then PPBV. Now this one, okay, of course Dr. Cheng has lectured at 2.8 kilogram, but we have a 1.9 kilogram neonate. Of course, we never entertained the idea of doing a femoral arterial access, but anatomy showed a TOF. So we have a chance of doing the PDA stent again through the right side of the heart, the antegrade approach. And true enough, we were able to stent through the femoral venous side, going to the RA, VSD, then to the dilated aorta, to the pulmonary stenosis, then do the pulmonary balloon valvuloplasty. So the PPB wire is anchored in the stent, then we are able to convert the critical PS to a functioning valve. okay, to preserve the biventricular repair of our surgeons in the future. This is a 1.9 kilogram neonate. Now, this is the last case. Actually, I did this case 2 days ago, Wednesday. So, antegrade approach with body wire support. A 21 days old patient, tough atresia with vertical PDA. But during our injection at the aortic side, it's not just a vertical, it's almost 120-degree tortuosity going to the left side, then going to the right side with a constriction. So what I did, okay, I injected the ascending aortogram side, and that's the best approach to access the stent. And from the right side, antegrade approach, I was able to do the stent. But the problem is, during the access of the transverse arc, there's buckling of the wire, and there's almost slipping of the wire. So I utilized the body or double wire technique to have a good support. And enough, I was able to stent that PDA. But I choose which of the wire has best anchorage. And I think the most distal wire, the distal RPA, is the best anchorage wire. So before inflating the balloon, I removed that another wire at the lower side of the right PA. Another thing about this patient, I thought that there was some sort of constriction at the proximal side. So I was entertaining of doing a telescope on the proximal side, but on the lateral angiogram right after stenting, there was a good opposition. The whole span of the PDA was covered, so I decided not to do a telescope and remove and do a stent, post-stent angiogram. So what are the learning points? Through the years, we all know that almost all PDAs from the viewpoint of interventionalists are stentable. Of course, you have to follow strict inclusion criteria, follow the institutional protocols. Personally, I think the two major criteria is the size of the patient and the morphology of the PDA. Intra-procedural strategies, technical innovation can spell success or doom in any PDA stenting procedure. But of course, strategies differ institutions to institutions and operators. Always remember that you should have a complete skills in the kit. But what if you are confronted with this kind of anatomy? This is a 1-day-old non-confluent pulmonary artery, tough. Okay, the right PA coming from the innominate with two tortuosities, the LPA coming from the underbelly of the aorta. So, are we going to stent or not to stent? Just send this patient to Dr. Morgan. What do you think, Dr. Alwi? With this anatomy?
Yeah, I would stent it because you need two petitions otherwise.
I think that's all. Thank you.